we're going to turn it over to Dr. Chakra.
Thank you, Tom. Thank you to Dr. Cressy and Dr. Lai. Also, I want to thank Cindy and Charlie for including me in this webinar series. We have a great group of people here at Shin Imaging. All of our radiologists are board certified and have completed additional fellowship training in subspecializations such as neuroradiology, interventional radiology, mammography, body imaging, and musculoskeletal radiology. A little background about myself. I trained at USC LA County for radiology residency and completed an additional one-year fellowship in musculoskeletal imaging. And during that time, I was able to work with a lot of the USC athletes, including the USC football and basketball teams. For instance, Mark Sanchez, pictured here, was injured and had his imaging completed at USC. So I was involved in interpreting their imaging studies, performing imaging-guided procedures such as steroid injections and arthrograms. And then later I would have the chance to watch some of the athletes compete on television. So that was a great experience for me and definitely a lot of trauma. So what is a musculoskeletal radiologist? An MSK radiologist is subspecialized in imaging and imaging-guided procedures related to the musculoskeletal system. For instance, this is a paper that we published in AJR regarding orthopedic hardware. The images on the right demonstrate placement of an endoprosthesis for limb-sparing surgery in the distal femur and proximal tibia. And this was a project that we completed in collaboration with Cedars-Sinai. We worked side by side with orthopedic surgeons, obtained intraoperative imaging, and correlated the findings in the OR room with what we saw on the plain films and advanced imaging. MSK radiology also focuses on bone disorders and bone tumors. For instance, we published this paper in the Journal of Radiographics on giant cell tumor of bone. The image on the right shows giant cell tumor extending through the distal femur, labeled by the arrows here. And MSK radiologists perform bone biopsies and other imaging-guided procedures. So in this image, I used a drill to enter the cortex of the posterior right iliac bone. And then after drilling through the cortex, went down, advanced the needle, and took a biopsy of the sclerotic lesion. And this ended up being a prostate metastasis. And before I discuss trauma, I want to highlight a case from Shin Imaging that was recently accepted in the E-Anatomy Atlas of Human Anatomy. This atlas is used by radiologists across the country and throughout the world. I personally used it as a radiology resident, and it's also a resource for medical students and faculty for teaching. And here's that patient from Shin. The patient was a 19-year-old male, and as you can see, the imaging is very high quality. This slice is right through the level of the glenoid labrum, which is outlined perfectly here. And the bright signal is the contrast from the joint injection, outlining the glenohumeral ligaments. So just some beautiful image quality for the anatomy, and this was published a few months ago, January 27th, 2020. And I'm grateful to be working at an imaging center with such high quality images that are worthy of publication in an atlas. So what is the role of magnetic resonance imaging in musculoskeletal trauma? Well, Dr. Lai and Dr. Cressy mentioned some of the uses of MRI and the role. So I'll discuss them here. Osseous contusion or bone bruising, hemarthrosis or bleeding into the joint, occult fracture, which is a fracture that can be missed on plain films or other imaging modalities, but is detected on MRI, and muscle tear, tendon tear, ligamentous injury, avulsion injuries, and cartilage injury. Bone bruising or osseous contusion is injury to the trabecular portion of the bone. So the image on the right shows that bone has a cortical outer layer of hard bone, and inside is what's referred to as spongy bone or trabecular bone. And the image on the left is a scanning electron microscope image that shows this meshwork and trabecular pattern. So bone bruising or osseous contusion is microtrabecular fracture. And within these spaces and holes of the spongy bone or trabecular bone is blood vessels and bone marrow. So when there's microtrabecular fracture, there's injury to those vessels and the marrow. And this is what it looks like on MRI. This is a sagittal image through the lateral compartment. And as you can see, there's bright signal in the lateral femoral condyle and the posterolateral tibia from osseous contusions. And this specific pattern is referred to as kissing contusions. In other words, there was anterior tibial translation, which is usually from an ACL tear. And this part of the tibia impacted upon the lateral femoral condyle, leading to the bone bruising. Hemarthrosis is bleeding into the joint or hemorrhage into the joint. And this is a specific type of hemarthrosis called a lipohemarthrosis. And this occurs when there's a break in the cortex. This dark line here is the cortex or the outer portion of the bone. And when there's a break in the cortex or fracture that extends to the joint, the marrow leaks into the joint. And we have a trilaminar appearance referred to as the Neapolitan ice cream sign. And the Neapolitan sign, the star here is labeling the non-dependent portion of the fluid, which is the fat from the marrow. The middle layer is the serum, and then the more dependent layer is the blood product that's more dense because the patient is supine on the exam table. MRI is superior in detecting occult fractures and subtle fractures that are missed on plain films and other imaging modalities. This is a case of a 27-year-old patient, and the frontal view plain film on the left was interpreted as normal. However, when the patient went in for MRI, we can see that there was a curvilinear low signal fracture line in the medial tibial epiphysis and metaphysis with surrounding marrow edema. This is an occult fracture of the ankle, and the plain films were interpreted as normal, but as you can see, MRI clearly demonstrates the curvilinear low signal fracture line extending to the talar dome and also the posterior subtalar joint with surrounding marrow edema. So how does 3T stack up against 1.5T for bone stress, fractures, and marrow edema? Well, it turns out for this particular type of trauma, there's not a big difference. Osseous contusions and fractures are pretty well detected, whether it's 1.5 or 3T. The only finding from that particular article is that the demarcation of the marrow edema is better delineated on 3T imaging. So there may be some uses for that, but overall not a huge difference. However, when comparing 1.5 Tesla and 3 Tesla for small joints such as the wrist, 3T is superior. Specifically, if you're looking for injury in the wrist, such as injury of the triangular fibrocartilage complex, the sensitivity, specificity, and accuracy of 3T MRI is higher compared with that of 1.5 Tesla wrist MRI. And here's an example. The image on the right shows the triangular shape of the triangular fibrocartilage complex, and MRI demonstrates a full thickness tear or central perforation of the central disc, as well as an additional partial thickness undersurface tear. And Dr. Lai mentioned using MRI to detect injuries of the thumb. So this is a case from Shin, and the plain films were read as normal. However, on MRI, just like Dr. Lai's patient, there's a full thickness tear of the radial collateral ligament of the first MCP joint of the thumb. And you can see the dark fibers here where the ligament is intact distally, but proximally it's torn, and some marrow edema in the first metacarpal head. This is another example from Shin of an avulsion fracture. And we talked about the timing of injury. And in this case, I can tell that the injury was at some time in the past because there's no marrow edema. but it was helpful because they suspected ACL injury due to trauma. And as you can see, the fibers of the ACL are intact. However, they're attached to this 3 millimeter avulsion fracture fragment, which came from the anterior tibia, the medial tibial spine. So I've discussed bone bruising, hemarthrosis, occult fracture, muscle tear, and some of these other injuries. Now I'm going to focus in on cartilage injury, especially because 3T reigns superior. And here's just an article, a retrospective study in which patients were imaged at both 3T and 1.5 Tesla for injuries of the knee. And the first case from that study, a 35-year-old male who reported locking and pain in the left knee. The image on the left is at 1.5 Tesla. And the radiologist read this as questionable signal change at the patellar cartilage. However, when the patient went in for 3T MRI, the corresponding abnormality was correctly identified as a greater than 50% thickness patellar cartilage lesion, and this was confirmed at arthroscopy. The second case is a 37-year-old male patient with swelling and contracture of the left knee. And in this case, no cartilage lesion was detected at 1.5. If you follow my pointer here, the gray signal of cartilage along the patella is intact. The cartilage along the trochlea was intact with no lesion. However, at 3 Tesla imaging, this was correctly graded and demonstrated a greater than 50% thickness cartilage lesion along the lateral patellar facet and verified by arthroscopy. This case is a 36-year-old male with suspected osteochondritis dissecans. At 1.5 Tesla, there was high signal along the subchondral bone that was thought to be delamination without a focal cartilage defect. And again, following this arrow, you can see that there's intermediate signal, this gray cartilage that looks like it's overlying the lesion. But when there's delamination, this can occur, but you want to look for the part of the delamination of cartilage that's extending to the articular surface. So the patient underwent imaging on 3T, which clearly demonstrates a full thickness cartilage defect with delamination, and this was confirmed at arthroscopy. And again, I just want to drive this home. 1.5T did not detect a cartilage lesion here. Maybe in retrospect, there's a small focus of signal change, but a cartilage defect was detected on 3T. And from our imaging center, this is a recent case where the patient had trauma. I think it was a twisting injury, and beautiful image quality. The cartilage is intact here following the lateral femoral condyle. And then right in the posterior weight-bearing portion of the lateral femoral condyle, an 11 millimeter full thickness cartilage defect with just a sliver of subcortical edema. And when you see a cartilage lesion that's this large, you want to look elsewhere in the joint to find that fragment of cartilage. And sure enough, it was found higher up in the suprapatellar region. This is the displaced cartilage fragment. And I called the orthopedic surgeon who referred this case to Shin, and he later took the patient for arthroscopy and confirmed these findings. So the most important takeaway message from this lecture today is really two things. Number one, 3T is superior to 1.5 Tesla in the detection of cartilage injury and cartilage lesions. And number two, for small joints such as the hand, wrist, fingers, and ankle, 3T is better than lower field magnetic resonance imaging. In summary, I've discussed the advantages of MRI over other imaging modalities, the types of MSK injuries detected with MRI, and the advantages of 3T over 1.5T for MSK trauma. Thank you for listening, and with that, I'll turn things back to Tom.
Let me actually ask you a question, Dr. Chakra. You're not off the hot seat yet. I'm just kidding. With imaging, you know, we deal a lot of times with non-obvious injuries. Is there anything, you know, if you don't have a fracture or if you don't have obvious edema, when you're looking at an MRI or maybe another type of imaging, are there signs or clues that tell you that something's acute rather than chronic or long-standing? I mean, and I guess we can leave it open to maybe shoulders or knees or ankles or hips or even the spine.
Sure. Yeah, absolutely. I'll give an example. So the case that Dr. Lai showed with the knee for that soccer player that had a chronic tear of the ACL, I could tell right away, I see him nodding his head, I could tell right away it was a chronic tear because there wasn't marrow edema, there wasn't much anterior tibial translation on the image, and those are secondary signs of ACL injury that we see. So probably the ACL was torn because it wasn't visualized, but it probably scarred down over time.
And is there something that we can say is acute at times on imaging where you, as a radiologist, you're looking at it and you say, wow, okay, that's clearly acute?
Right, yeah, absolutely. We look for marrow edema. We see fluid signal, we see subcutaneous bruising, joint effusion. There's a lot of things that we use to piece it together. And usually, at least for a musculoskeletal injury, we can usually say whether this is acute and related to the trauma or not. We do get some referrals where the patient had an MVA that's 2 years ago or a year ago. And in those situations, it's kind of difficult because we don't have the secondary signs or the bone bruising, the edema, all of that is resolved. But in general, as long as you get the imaging done quickly, like Dr. Cressy mentioned, then yes, we can usually distinguish that.
Thanks, doctor. Turning to Dr. Cressy, we talked a little bit earlier about other injuries, mechanisms for other injuries in motor vehicle crashes like ankles or knees, shoulders or wrists. And have you come across any cases like that where it's not just a straight, spine pathology or muscle strain or sprain or disc herniation and you're dealing with an extremity?
Yeah, absolutely. Thanks for asking that question. I actually chimed in on that, and the reason I'm thinking of a few particular cases, and I'll usually go to the area of worst complaint to start with, and in many cases I'll see a lot of traumatic brain injuries and problems with disc pathology in the neck. Well, those types of injuries can mask other pathologies that are farther down in the extremities that they don't realize are bothering them. They really are only feeling 2 or 3 points of pain at once, and then as those start to settle out, they start to realize they have other things going on. A particular example, I had a patient who had a pretty bad concussion, and he had a disc pathology. So I MRI'd the areas of worst complaint, and then he just kept complaining about his wrist. He said, my wrist, when I grab, I try and open this jar, it just hurts, and I don't know why. Well, this is about 6 to 8 weeks later, and I MRI, and he had 3 wrist fractures in there that were starting to heal. And it was obvious that this came from the impact where he was holding the steering wheel and pulled back, and that's what caused it. So that's an example. We see shoulder injuries a lot of times from patients who are holding, say you're holding in a position, it's hard to do with this filter, but you're holding in a position like this, and the car hits you from behind, and what happens to your car? Your car goes forward, but your body goes back. So your hands are holding on and you pull, and you get a pull on the shoulder, and you have shoulder tears and ruptures in there that you can clearly correlate to the crash. But they're later discovered because first we're thinking neck, head and neck, and we're not necessarily looking at the shoulder initially. That might be like a secondary or tertiary investigative report that we do later on. So that's an example. And also I've seen many ankle problems or knee problems, dashboards hitting the knee, airbags hitting the knee, ankle being pressed on the brakes or on the gas pedal, and when you're getting hit, so you have trauma there. I've seen a couple of ankle fractures. I've seen problems with airbags from the knee will actually create an infection in the shin. So I've actually seen a couple of interesting cases there where we're having to send them out to the ER. So interesting stuff. Hope that answers.
Thank you for that answer. There's one more question actually for you, which is, you know, doing consecutive treatments. So you have a patient that comes in and they treat Monday and Tuesday consecutively. And as attorneys, especially in pre-litigation, where the vast majority of personal injury cases reside, and get resolved, insurance adjusters tend to give attorneys a hard time if there's consecutive days of treatment. And obviously the suggestion by the insurance adjuster is that this is over treatment or excessive. Is there evidence-based literature or practice supporting consecutive day chiropractic care or physical therapy?
Well, Tom, I wouldn't use the evidence-based literature to back up my argument here. That's just not the way that I practice. I'm a clinician. I don't know about all the evidence out there. I'll tell you what I see is from my experience. If someone's in severe pain and they're asking for help, and you say, well, you know what? The insurance company is going to give me a hard time if you come back tomorrow. Why don't you wait a week to come in because the insurance says you should? That just doesn't seem reasonable to me. If they're in an acute phase, we want to treat them as often as we can to help them. And sometimes it may be problematic with their schedule for transportation, or it might be there's a holiday and there's only a Monday, Tuesday, Wednesday office availability for them. So those are sometimes rare cases that happen where they'll get that kind of thing in a strange situation somewhere midway through the care. But if they have an exacerbation somewhere through the care and they can barely get out of their car and they need help coming in, I can't see why you would tell them that they'd have to wait 2 or 3 days. That just doesn't make sense to me. You're going to help them right now. If they went to the urgent care or the ER, they wouldn't be putting gaps in there about when doing different procedures. It just doesn't make sense. So you do what you can to help them from the perspective of what the right thing is to do. And that's the way that if they're in an acute situation, that can go for a short period of time. Now, if they're doing every single day for 6 weeks, that's overutilization. I think they should be seeing a specialist at that point if it's that bad. If it only, even like more than 2 weeks, they should probably get a specialist because they likely need something a little bit more to help them with their pain that's unmanageable. Does that
Thank
answer?
you. Absolutely, absolutely. And you know, just kind of to give just briefly, I know we're just out of time, but just to sort of wrap it up and give sort of the legal perspective on this. You know, as you heard, I've tried, you know, over 50 personal injury cases, and I've worked on probably close to 1,000, I'd imagine, if not more so. And I can't stress enough how important the very first set of treatment is. And everything from the onset of the trauma and the injury and the medical workup is critical, because whenever I'm gearing up for trials or whenever we're an expert discovery, the thing that's scrutinized the most by defense attorneys and insurance companies is that initial treatment and really looking at gaps in treatment or lack of documentation or excessive treatment. And I think, you know, all three doctors hit on really important points. In particular, this idea that, look, you're generally, or you're going to start out with some type of conservative care, but at some point, let's say you want to do additional conservative care, and I think Dr. Cressy really hit the nail on the head. You know, he's referring them out to a specialist at that point, maybe an orthopedic specialist, to see if there's some other pathology there that's causing the patient's symptoms that he can't necessarily alleviate. But at least you have documentation there that here is a patient who's not benefiting from conservative care. They're now seen by a specialist, and either an orthopedic specialist, maybe it's a spine surgeon, maybe it's a neurosurgeon, and they're checking in with that specialist, and the recommendation is maybe some additional conservative care. So you're getting treatment that's being sanctioned by another doctor. And I think when you have doctors that their diagnoses are consistent, or their treatment modalities that they're recommending are consistent, it helps support your argument not only to adjusters and defense attorneys, but when you're in front of a jury and you say, look, this person went and saw the chiropractor, This person went and saw a orthopedic specialist. This person went and saw a pain management doctor, and they're all saying the same thing. They've all recommended this course of treatment. And I think when you have that sort of unity and support in your cases medically, you're going to see a lot better results. And on top of that, this idea of over-treatment can be monitored, because you're not just having a chiropractor do 9 months of treatment without seeing a different specialist to get that point of view. So I think, all great points. And another key thing is to have everything match up. As Dr. Lai mentioned, you want to have a clinical correlation between the history of trauma, what you're finding on the exam, and then the imaging. And that's the perfect trifecta. And it's really hard for the defense to dispute that. I mean, if you have somebody that was involved in trauma, and they say, well, the trauma didn't cause all of the problems, it was degeneration, you run into a really bad argument there, because is it a coincidence that, my client Jane or my client Joe, they just happen to have an onset of symptoms after the trauma? And is it just a coincidence that the imaging matches up perfectly with their symptoms? I mean, did Jane or Joe happen to know what was going to be shown in the MRI, and they were just, perfectly planning their symptoms and how they were expressing them? So those are key things, is documenting the injury, making sure that they're seen by the proper doctors throughout the course of treatment, and really making sure you have that trifecta of history, exam, and the imaging that correlate. So with that, I know we're out of time, but I want to thank everyone that came out to listen to this webinar. And I want to thank our panelists, who are amazing, just super informative. Thank you for taking time out of your busy practices to share with us this information.